Hi, good afternoon. I'm going to talk about rotator cuff injury. I've seen many of them in my practice. I'm going to talk about 2 case studies on rotator cuff, and in SOT, the classic SOT ties in with category 2. And category 2 ties in with lateral side neck pain, shoulder and arm, lateral side headaches, pain down the side of the leg, front of the leg into the groin, medial knee, ankle pain. It also ties in with the liver, the pancreas, and the adrenal system, and also the TMJ, and so bruxism type thing. So category 2 is classically related to rotator cuff. And a lot of times, so you just push this button on the right. Basically, this is my address and my email in case you want to contact me. Oops. So we do this. Okay, this shows the rotator cuff. And in, most of the time I see rotator cuff tears. They say there's a tear, but actually, from my evaluation, there's no rolled up ball of muscle. So there's it's a tear, but what actually I see is happening is the ligaments get stretched out and the muscles try to support the joint. And so when the muscles try to support the joint, they work all the time. And so then they stay tight. And so they restrict motion. And so category 2, the biggest ligament related to category 2 that I'm aware is the SI. And there's an upper and lower boot. And so that can tie directly right up to this rotator cuff. There's 2 case studies that I was going to talk about. One was a 60-year-old, very normal, healthy male, very active, liked to cut wood, and he was having some shoulder pain, and he was able to raise it 90 degrees in flexion and abduction, and it was restricted past that point. Another case, case 2, is a 90-year-old male. He's actually over 90, chronic low back pain, and then during the course of the treatment, he told me about his shoulder, and then I checked it, and it needed to be treated in order to help the low back. And so he said, don't bother. It hasn't worked for 2 years. Don't worry about it. And it would abduct to about 90 degrees, flexion and abduction. This shows part of the treatment. There was 3 areas that I taped related to the rotator cuff. One was the SI area, and after I taped the SI area, I would treat it for category 2. And I learned this, what they call neutral category 2, which has to do with instead of one ilium rocking back and having extension, both iliums rock back and have extension. And I learned about this from Dr. Skipstead and Bunting back in 2000. And basically, what happens when they both rock back, then the head moves with the pelvis, and the pelvis moves with the head. And if both of them are rocked back, then the iliums moved with the temporal zygomatic maxilla area. And so then that rocks back, and when that rocks back, then the nose nasium gets a little bit higher, and the whole head kind of shifts back into neutral. And so what you do is you put the blocks in down here on the top of the crest on both sides, and so you bring it out of neutral in the pelvis, and then there's a cranial adjustment to bring it out of neutral in the head. And so I did that after I did the taping in each of these cases to help to bring more full function to the SI related to category 2 and more full function related to category 2 to the TMJ in that upper cervical area. And most of your motion in your neck happens between the occiput C1, C2. It's about 80 to 90% of the motion comes from there. And so you're getting at opening up these nerve pathways in the the cervical and upper thoracic area. And so the other thing I did was I cleared the category 3 first, and then worked on the category 2 indicators, and then specific category 2 testing. And then each of the visits, since I checked the shoulder quite thoroughly each visit when people come in, I would do an adjustment if it was restricted. And the adjustment would bring back quite often 10 to 30% of the motion in the shoulder from the 90 degree. And then after the taping, you'd get usually another 10 to 30 degrees a motion from the taping, and then then I did the neutral category 2, and a lot of times you get another 10 to 30 degrees of the motion. This shows the taping, and basically you start about half to 2/3 down on the pelvis, and then you just move up. You kind of like shingling a roof. You go up, and then it stays on a little bit better, and then you have to push the tape on once it's put on. And it wasn't stretched; it was just laid on. And what I do is I bring the knee into the opposite popliteal fossa of the back of the knee, and then I go ahead and do that taping, and then the tape stays on for about 3 days, and so this shows it on both sides. And a lot of times both sides are sprained when you have a rotator cuff injury, because the category 2 mechanism relates to those areas. This shows the second series of tapes. This ties in with the AC, or the sternoclavicular and the AC joint. And so I stretch the arm back, I stretch the anterior deltoid, bring it back like pulling a bow back. And then I tape this area, and then I tape the next area, which is the AC joint. And I go towards the neck. And then that's just laid on, both of those. And then I put some anchors on across that helps to cinch it up, to tighten up those ligaments between the bones there. And usually I have to put 2 on. This here is the third taping, and after each of these taping, what happens is your sacrum moves a little bit more forward, and you get another neutral category 2, so you unlock that with the pelvis with the blocks. And then I go ahead and do that cranial adjustment for the neutral category 2. And this is for the slip bicipital tendon. And what I do for that adjustment is I loosen the shoulder this way, and then I loosen it this way, that way, and then I bring it up like this to stretch it back that way, and then I stretch the radius ulna and then the wrist bones right up in there. And so then I bring the shoulder back again. This is after 3 days at least. Sometimes the one patient came in once a week. It was kind of busy, and then it was 6 visits, and the other patient came in twice a week because he was over 90. He wasn't quite that busy, kind of relaxed. So anyway, so we just taped that area, laid it on with a elbow back like that, and usually I use 2 pieces of tape for that. They're about a little over a foot long, and then this this is a different person, and the second area is the forearm, the distal, and then the proximal forearm is worked. And then when you test this, the hand web will get tight when you get it in the right directions. Usually it's thumb straight up. It'll be really tight. And then when you put the tape on, then it loosens up. And so basically that's how that works. And so basically you could get them better than, 6 to 8 visits even in some cases, because it goes relatively quickly. But you don't want to see them more than every 3 days, because you need to have time for the tape to do its work, and it works 24 hours a day. And basically how it works is when the skin changes shape, it changes the position where the joint is at. And so when you get the joint approximate, the skin is in a different shape. And then you lay the tape on there, and then that holds the shape of the skin, so it holds the bones together 24 hours a day. And so then it's just like a bad sprain that needed to be healed, and then it can heal. And it's not that hard, really. It's pretty simple. So that's why I'm presenting this, because it is relatively simple, and it works quite well. And there are difficult cases of rotator cuff, but they're much, I usually don't have, usually I have very little trouble with them with this procedure. It makes it actually a lot of fun to help people with that. Let's see. So, and then at the end of it, I do a category 2 cranial sutural. And if they have it on the right and the left side, strains on both sides, I'll do a sutural after I complete either the right or the left, and then I'll complete the other side, and then I'll do another sutural after that. And that's helps to balance, that balances the head with the pelvis so that it's in sync. Let's see here. So this talks about amount of time. And case 1, he got about 170 degrees full flexion and abduction after the treatment. Case 2, he got about 160 degrees flexion and abduction. And actually, he could use it real easy. You know, he could, both of them. And the one case, he came back. He came about every 5 to 6 weeks after that treatment, and then he had relapse after about 1.5 years or 2, where he overdid it again. And so he, you know, basically responded in 2 or 3 visits at that period in time. So basically, that's where I'm at. And lateral side neck pain, shoulder and arm, lateral headache, lateral side headaches, pain down the side of the leg, front of the leg into the groin, medial knee, ankle pain. It also ties in with the liver, the pancreas, and the adrenal system, and also the TMJ, and so bruxism type thing. So category 2 is classically related to rotator cuff. And a lot of times, so you just push this button on the right. Basically, this is my address and my email in case you want to contact me. Oops. So do this. Okay, this shows the rotator cuff. And in, most of the time I see rotator cuff tears. They say there's a tear, but actually, from my evaluation, there's no rolled up ball of muscle. So there's it's a tear, but what actually I see is happening is the ligaments get stretched out, and the muscles try to support the joint. And so when the muscles try to support the joint, they work all the time, and so then they stay tight, and so they restrict motion. And so category 2, the biggest ligament related to category 2 that I'm aware is the SI, and there's an upper and lower boot. Hi, good afternoon. I'm going to talk about rotator cuff injury. I've seen many of them in my practice. I'm going to talk about 2 case studies on rotator cuff, and in SOT, the classic SOT ties in with category 2. And category 2 ties in with